Chapter 7 Mental Health Assessment. First off, we need to define exactly what is mental health. Mental health is a state of well being, ability to recognize one's own abilities, and most importantly, able to cope with the normal stresses of everyday life. It's a capacity to rationally think, communicate, learn, grow emotionally, and have self esteem. This is a topic we're going to get into much deeper next term in mental health as well, is differentiating between mental health and mental illness. Nobody is completely mentally healthy, just as almost nobody is completely mentally ill. Everyone falls somewhere within that continuum, somewhere within that range. And as stresses occur, they can be pushed further towards that mental illness side. For us right now, mental status is going to be defined as that degree of competence, shows intellectual, emotional, psychological growth, personality. Interpersonal violence. This is also going to be an area you're going to deal with in a wide variety of nursing specialties. And abusive experiences may influence a person's mental health, and further compounded even with things like alcohol abuse, drug abuse, personal abuse. Interpersonal violence, and especially domestic violence. It's not an illness, but a crime and a violation. It can have severe negative impacts on that patient's mental well being. For anatomy and physiology, we're going to be looking at things like memory, basic emotions such as fear, anger, sex drive, and how these structures enable communications between the limbic system and the cerebral cortex. Neurotransmitters. These are going to be essential chemicals that help our brain function. These chemical vehicles work to carry messages from neuron to neuron or neuron to muscle cell. They can be synthesized within the neurons, released within synaptic clefts, and bind to receptor sites on the neurons or effector cells. And these neurotransmitters then return to storage through reuptake, are degraded by enzymes, and diffuse into the nerve terminal. This will be another one we're going to especially talk about here in pharmacology as we start talking about drugs like SSRIs, selective serotonin reuptake inhibitors. And here we just have a diagram showing how those neurotransmitters work to transmit messages between neurons at that synaptic cleft. Due to this pivotal role neurotransmitters play, they also play a key part in our mental health. Transmitters like norepinephrine, serotonin, dopamine, histamine, acetylcholine, and GABA, just to name a few. Here we have another diagram just showing the neurotransmitter role in between the presynaptic nerve terminal and the postsynaptic cell, where that nerve transmitter's attaching to the receptor. We begin our mental health assessment right there at the beginning of our general health history. Because this data is collected by talking with the patient, the nurse can collect a wide variety of data. Everything from their demeanor, their alert, are they A&O times 3, A&O times 4, their cognitive function compared with characteristics of a healthy personality. We'd be looking at things like, is the patient dressed appropriately for the weather? Does his or her mood seem appropriate? How was that patient's affect, their demeanor? How's their body posture? Are they slumped over, looking at the ground with a sad facial expression? Are they walking tall, brisk step? Are they smiling? How's their tone of voice? Is it monotone? Is it expressive? And does that nonverbal demeanor, that nonverbal communication, match up with the verbal communication of what the patient's saying? Are both of those messages congruent? Affect is a term we're going to use a lot, especially here as well as once we get to mental health. And affect is defined as that observable emotional expression, compared with a mood, which is more of a subjective emotional state. Some different types of affect you may hear would be flat, no emotion, complete lack of expression. Blunted means they're showing minimal emotion. The patient's labile, meaning their affect is changing rapidly, wild variations. And then again, that inappropriate is it doesn't match the situation. As we assess the patient's present health, we'll be looking at, are you having any medical problems? What medications is the patient taking? Side effects of some medications may cause changes in mood or behavior. And we need to know if the patient is taking these medications for a mental disorder or for a different condition. This would be especially useful in the case of anticonvulsants. Many anticonvulsants used to treat seizures are also used in a mental health capacity as a mood stabilizer for things like bipolar. And it's not just enough that we know what that patient is taking. We also need to know why they're taking it. For our past mental health history, in the past, have you experienced any behaviors that could indicate a mental health problem? Do you have any blood relatives with behaviors that could indicate a mental health problem? Has the patient witnessed any violence? Do they have any traumatic events that occurred in their past? All of these things are going to add together to give us a better idea, a better understanding of the patient's overall mental health status. We also need to look at the patient's self esteem and self concept. Looking at things like how the patient's been feeling about themselves. Do they consider your present feelings as being a problem in everyday life? And how would you describe yourself to others? What is your best characteristic? In these cases, we also need to be putting it a top priority. Are we assessing for that patient for any risk of danger to themselves or others? When we start talking about mental health assessment and assessing the patient's mental health status, that assessment for danger to self and others has got to be a top priority. Also, looking at the patient's social life. How satisfied are you with your interpersonal relationships? Are there people you feel like you can talk to about your feelings? Also, because abuse and violence have been more common, all patients should be asked, are you being physically injured by someone in your home over the last year? Are you fearful of anyone you've had a relationship with? And do you feel safe at home? Stress is universal. Every single person out there feels some form of stress in one form or another. Have there been any recent changes in your life? Have these affected your stress level? What are your major stressors in life, whether it's work, family, financial? How do you deal with those stresses? And are those methods effective for you? And anger. Have you been feeling angry? Do you feel angry now? How do you react when angry? Would it be verbally, physically, or do you keep that anger bottled up inside? We all fight at home, but what happens when your partner fights? Are they able to effectively reach a resolution? Or are they dealing with this in a very unhealthy manner? Alcohol and drug use are going to be another key part of this assessment. Every adult and adolescent should be asked about alcohol and recreational drug use, especially with alcohol. How often do you drink alcohol, including beer, wines, liquors? This is going to be key for everyone, especially for the elderly and geriatric population as well. If you go back a few generations, alcohol was even more present and much more present in society than it is today. Not that alcohol isn't very present now. And you're seeing a lot of alcoholism as that baby boomer generation is entering retirement. Also, recreational drug use is going to be pretty universal no matter what part of the country you're in. For our problem based history, commonly reported problems of mental health, we're looking at things like depression, anxiety, altered mental status. And again, just we talk about that substance abuse from the previous slide, how that can have a compounding effect on depression, anxiety, and the patient's current well being. For a depression assessment, we need to note the gender, age of the patient. Women are at risk of depression at a 2-to-1 rate over men, and it most commonly occurs between the ages of 25 and 44. You also need to pay special attention to things like facial expression, eye contact, body language, and tone of voice. During the past month, if you've been feeling down, depressed, hopeless, that little interest or pleasure in activities, an inability to feel pleasure is going to be a term we talk about a lot in mental health called anhedonia. Are they able to fall asleep and stay asleep? Difficulty sleeping is going to be a key part of depression. They can have serious detrimental effects for the rest of their life. Have the patient describe their mood. Do they have crying spells? Are they having difficulty concentrating? They've been feeling more irritable. And how often do they have these feelings? How long do they last? Again, with depression, we need to talk about things like, do they have friends or a support system, people they can trust, who are available when they need them? How often, do they have these feelings? What do you do about these depressive feelings? And again, we need to put that danger to self and others as a top priority. Have you ever had thoughts of escaping by hurting yourself, ending your life? Are you a danger to yourself or others? And if yes, do you feel like this now? And then if they do identify that they are a danger to themselves or others, we need to ask if they have a plan. Some patients may say no, suicidal ideations are vague, versus others who have a very specific plan. And again, for anxiety, if the patient have any difficulty in concentrating or making decisions, a little bit of anxiety is normal. Everyone has a little bit of anxiety. Just from an evolutionary standpoint, back in the hunter-gatherer caveman days, the caveman who was seeing danger around every rock and corner tended to live longer. Now in modern life, where those dangers aren't necessarily present, the anxiety just makes you miserable. Are they able to fall asleep and stay asleep? Have they been more irritable? Are their muscles tense? Do they feel a tightening in their throat? Nauseated? Heart rate? Do they urinate more? Have they noticed any changes in feelings? When assessing for altered mental status, keep in mind that changes in mental status may become evident when there's a change in the patient's orientation, time, place, person, attention span, memory. When orientation becomes a concern while taking a history, the nurse should ask to collect additional data. Long term memory can be assessed during the history by asking the patient where he or she was born, ask about their previous surgeries. These major life events that happened years ago, are they able to recollect them to get that long term memory assessment? The MMSE, the Mini Mental Status Exam, I've actually attached a copy down below in the LMS as well for you to wrap up. Just complete the MMSE yourselves, or at the end of class, you guys are able to buddy up and complete them on each other. But this is a tool to assess the patient's cognitive function. It has a maximum score of 30 points, with 24 to 30 being normal, 18 to 23 meaning mild cognitive impairment, and 0 to 17 meaning severe impairment. And here we've just got another copy of that MMSC. It's going to be assessing things like orientation, registration, attention and calculation, their ability to recall, and language abilities. Would be assessing the patient's judgment, their ability to make safe, realistic decisions. What would you do if you smelled smoke at night? If you found a stamped envelope on the ground, what would you do? Poor judgment may appear in things like dementia, psychosis, intoxication. When it comes to drug abuse, keep in mind some people use or have used recreational drugs in the past. And that recreational drug use may include illegal drugs, such as heroin, cocaine, or even marijuana, which is in kind of a gray area. It is legal in some parts of the country and illegal in others. And for each drug reported, ask how often have you used it? Do you have a strong desire for it? And have you tried or failed to control or even cut down on your usage? When it comes to assessing for alcohol, we're going to be looking at things like the cage screen. Cut down, annoyed, guilt. Do they need an eye opener? Are they drinking first thing in the morning? And two or more yes answers means a positive screen. There's also a much more common scale out there, the audit scale, that's used to assess alcoholism. That I'm going to attach that one below as well. For interpersonal violence, if the person answered yes during earlier screenings about interpersonal violence, follow up with the patient in private. You're asked about violence because so many women are dealing with this in their homes. If the abuse is a problem, you can either talk to you or you can direct them towards appropriate resources. Interpersonal violence can take a lot of different forms. Has your partner destroyed things you care about? Has your partner ever threatened or abused your children? Has your partner ever forced you to do something you did not want to do? And has your partner prevented you from leaving the home, seeing friends, getting a job, or continuing your education? When it comes to infants, children, and adolescents, variations for neonates and infants include asking about drug and alcohol use of the mother during pregnancy. Children are asked about experiences in school, if they like school, if they get into trouble, and any fears about any aspect of their lives. Adolescents are also going to be asked about their school experiences, as well as their drug, alcohol uses, any symptoms of depression or anxiety. When assessing older adults, indications of depression in older adults may be misinterpreted as expected manifestations of aging. Decrease in appetite or fatigue, maybe a decrease in metabolism or a loss of taste buds. Problems concentrating or sleeping may be interpreted as expected change of advanced age. And many think depression will go away without intervention, that they're too old to get help, or reporting sadness may be a sign of weakness. This is the PHQ-9. This is a very common depression screening scale that can be used for the elderly, though is also used in depression for all adult patients. That's another one I'm going to attach at the bottom. The PHQ-9 is a scale from 1 to 27. 20 to 27 would indicate severe depression. 15 to 19 is moderately severe depression. 10 to 14 is moderate. 5 to 9 is mild depression. And 1 to 4 is minimal depression. Because again, just like with anxiety, everyone has a little bit of depression. It's once that depression becomes so severe that it's impacting their daily life that we really start looking at it as a mental illness. Suicidal ideation, I say again, is a top priority whenever we're talking about any mental health, mental status, and mental health assessment. It's got to be that top priority, both here in our mental health course, as well as when we get to ATI and NCLEX. Always assess directly, non judgmentally. Are you thinking of hurting or killing yourself? Do you have a plan? And keep in mind those key risk factors: depression, substance abuse. Prior attempts is going to be a major indicator that they could attempt again. Also, key terms like hopelessness or feeling like a burden are going to be other of those key phrases that we really need to zero in on. Bipolar disorder. Think of a patient's mood like a pendulum. Everyone's got to have swings of light depression, happiness, depression. In the case of bipolar, the swing of that pendulum is much more pronounced. If they're going to severe depression, severe sadness, to severe joy, running a mile a minute. Bipolar disorder is characterized by those episodes of mania, depression, or even mixed moods. And those moods can switch rapidly as well. In the manic phase, the patient would exhibit excessive emotional displays, excitement, hyperactivity accompanied by elation or delusions of grandeur. Whereas the depressive phase is marked by apathy and feelings of profound sadness, loneliness, guilt, or low self esteem. Schizophrenia. This is going to be a group of psychotic disorders that are characterized by severe disturbances of thought, associative looseness, hallucinations, whether they're visual, auditory, impaired reality testing, limited socialization, and some clinical findings could be everything from flat, blunted, or bizarre emotions, disorganized thinking, jumbled or illogical speech, impaired reasoning, and severe ambivalence. When assessing thought content, we want to look at what the patient thinks, not how they think. We're assessing for delusions, false beliefs, any obsessions, unwanted repetitive thoughts, phobias, suicidal or homicidal ideations. And finally, for non psychotic disorders, anxiety. Anxiety is a feeling of uneasiness, discomfort from mild anxiety on up to panic. Unlike fear, anxiety is the response to no specific source, no actual object. The energy that anxiety provides may mobilize a person to take constructive action, such as solving a major problem, filling an unmet need. There are some benefits to mild levels of anxiety. It's again, just like with depression, when that anxiety raises up to a level where it's having detrimental impacts to their daily life, that's when we're going to start treating this like a mental illness. But anyway, that's all I got for this chapter. I'll see you in the next slides.